You sit at the kitchen counter. The sunlight slants across the countertop. A cup of tea steams in front of you. Your knees ache when you shift your weight. Fingers trace the rim of the mug. You glance at the newspaper. The headline catches your eye. Not about finance, not politics, but health. Another surgery might help you move easier, it says. You nod slowly, not fully hearing it. Your back tightens as you stand, muscles reminding you of the morning walk you skipped. You feel the pull along your spine. Small noises, the fridge humming, a car outside, fill the kitchen. The thing is, surgery isn't always straightforward. Not after 60. Bodies change. Healing slows. Bones and joints respond differently than they did in your 40s. Research from the National Institutes of Health and peer-reviewed studies suggests something you may not have considered. Some common procedures offer less long-term benefit for older adults than people assume. At the same time, other interventions, often simpler or less obvious, can preserve independence, reduce fall risk, and improve daily function. It raises the question you don't usually hear at the doctor's office. Which procedures genuinely protect your long-term health, and which are steps that seem helpful but might not change the outcome you care about most? Moving, seeing, thinking, living on your own? The answer isn't in a single headline. It's in the patterns of data collected over decades, and in the moments you notice your body resisting again and again. You're at a medical clinic. A poster shows a smiling older adult walking easily, arms swinging, no cane. The caption, "Surgery restores freedom." It makes sense. Pain shows up. Hips, knees, spine, they ache. You think, if it hurts, fix it. If it's worn, replace it. The logic seems straightforward. Many seniors believe surgery is always the strongest solution. Chronic back pain, surgery. Stiff knees, surgery. Droopy eyelids, surgery. But decades of observational studies and clinical trials reveal a more nuanced picture. For instance, research published in the Journal of the American Medical Association shows that spinal fusion for age-related back pain without nerve compression often produces results similar to non-surgical treatment after a year. Temporary pain relief? Yes. Long-term improvement? Less certain. Similarly, knee arthroscopy for degenerative arthritis, according to NIH-funded trials, may provide short-term relief in select cases, but does not reliably restore function or prevent progression of joint degeneration. Muscle strengthening and physical therapy often achieve comparable outcomes. Even elective cosmetic procedures in older adults carry documented risks that are not always intuitive. The American Society of Plastic Surgeons notes that aging affects tissue healing, anesthesia tolerance, and recovery time. Complications that are rare in younger adults appear more frequently after 60. The confusion persists for several reasons. Media emphasizes success stories. Brochures highlight dramatic before and after images, and many clinicians face time pressures, sometimes focusing on the immediate symptom rather than the trajectory of long-term independence. In practice, older adults may overestimate benefit and underestimate recovery demands. They often miss that some surgeries protect function, vision, mobility, heart rhythm, while others mainly address a single symptom with limited effect on daily life. Recognizing these patterns isn't about fear or judgment. It's about understanding what the research actually shows, separating common assumptions from evidence, and seeing that aging changes the balance between short-term relief and long-term independence. A clinic hallway smells faintly of antiseptic. You watch a nurse wheel a patient past. Slow, careful steps. You notice the brace on the leg. You see it almost automatically. This body, these joints, this recovery path. Data from decades of research help clarify what procedures matter most for older adults. Take spinal fusion surgery. Studies in the New England Journal of Medicine and large observational cohorts indicate that for chronic low back pain without nerve compression, outcomes at 1 year are often comparable between surgery and structured non-surgical care, including physical therapy, targeted exercise, and posture correction. Recovery can take months, and muscle deconditioning is a documented concern. Knee arthroscopy provides another example. Multiple NIH-supported randomized controlled trials have compared arthroscopic cleanup procedures for age-related osteoarthritis to non-operative care. Findings show that improvements in pain and function are often temporary, and in some cases, patients achieve equal or better long-term results with quadriceps strengthening, low-impact exercise, and anti-inflammatory management. Limitations include variation in severity of arthritis and patient adherence to rehabilitation programs. Cataract surgery, by contrast, has robust evidence for improving functional independence. The American Academy of Ophthalmology reports that removing cloudy lenses improves visual acuity in the vast majority of patients and is associated with decreased fall risk. Large-scale cohort studies demonstrate that post-operative improvements in daily tasks, reading, driving, navigating steps, are measurable within weeks. Hip replacement has similarly strong data. Peer-reviewed trials and registry analyses show that older adults with advanced osteoarthritis experience significant improvements in mobility, pain reduction, and overall function following total hip arthroplasty. Timing matters. Delaying surgery until mobility is severely compromised may prolong rehabilitation and affect long-term outcomes. Pacemaker implantation provides a documented intervention for symptomatic bradycardia or certain conduction disorders. Evidence from the Heart Rhythm Society and large registries confirms that PACE patients experience improved cardiac output, reduced syncope, and enhanced functional capacity. Procedures are generally low risk with modern techniques, and benefits extend to quality of life metrics. Across these examples, the pattern is clear. Evidence supports interventions that restore function, vision, mobility, cardiac rhythm, while caution is warranted for procedures addressing pain or appearance alone, where long-term benefits are less certain. Even with strong data, limitations remain. Individual response varies. Comorbidities, frailty, and adherence to rehabilitation influence outcomes. Observational studies can identify correlations, but not causation. Clinical trials often exclude patients with multiple chronic conditions, meaning real-world results may differ. Recognizing these distinctions allows seniors and caregivers to weigh medical decisions with data-informed clarity, rather than relying on assumptions, anecdote, or advertising alone. You lift a book from the shelf, your knees bend, hips flex, adult pressure spreads through your lower back. Every joint moves in concert, muscles, tendons, ligaments, all coordinated. You barely notice it, but this coordination is the result of years of cellular adaptation. Take hip osteoarthritis. Cartilage is designed to cushion bone during movement. Over decades, repetitive stress and age-related changes reduce its thickness. Bone begins to bear more load. Synovial fluid becomes less effective at lubrication. The surrounding muscles weaken if activity decreases. According to the Arthritis Foundation and studies published in Arthritis and Rheumatology, this combination leads to pain, reduced range of motion, and altered gait mechanics. The cycle reinforces itself. Less movement leads to more muscle atrophy, which increases stress on the joint. Knee degeneration follows a similar pattern. Articular cartilage thins. Ligaments and menisci adapt to changes in alignment, sometimes unevenly. Quadriceps weakness reduces natural shock absorption. NIH-funded trials show that targeted strengthening of the quadriceps improves knee stability and reduces symptomatic load on the joint, effectively functioning as a biological cushion without surgical intervention. The spine is another complex system. Vertebrae are linked by intervertebral discs and ligaments. Discs act as shock absorbers, allowing micro-movements between segments. When spinal fusion joins two vertebrae, adjacent segments absorb extra stress. Over months, surrounding muscles may weaken due to limited mobility. Research from orthopedic journals shows that this altered biomechanics can lead to stiffness or discomfort in neighboring areas, a phenomenon called adjacent segment disease. Vision involves another set of systems. The natural lens gradually loses transparency due to protein aggregation in lens fibers. Light scattering increases, reducing acuity. Cataract surgery removes the cloudy lens and implants a clear artificial lens. Retinal photoreceptors receive focused light again. Studies from the American Academy of Ophthalmology link this restored input to improvements in balance, navigation, and coordination, because visual signals guide motor control in the cerebellum and proprioceptive system. The heart's electrical system is similarly precise. Pacemakers support the sinoatrial node and conduction pathways when the intrinsic signal slows. Electrical impulses are transmitted via leads to stimulate ventricular contraction. This ensures adequate cardiac output, maintaining oxygen delivery to tissues, including the brain and muscles. Cohort studies from the Heart Rhythm Society demonstrate that paced patients maintain steadier blood pressure and reduce episodes of syncope, indirectly protecting balance and functional independence. Even seemingly minor changes in muscle mass and neural control matter. Sarcopenia, the age-related loss of skeletal muscle, reduces strength and stability. Resistance training improves fiber recruitment and neuromuscular junction efficiency. Controlled movement stimulates proprioception, preserving coordination and reducing fall risk. Across systems, the principle is consistent. Aging alters structural integrity, regenerative capacity, and coordination. Surgical interventions can restore structure or function, but their effects depend on the body's underlying physiology. Recovery requires muscles, connective tissue, and neural pathways to adapt. Evidence shows that when these mechanisms are supported through physical therapy, careful surgical timing, and functional rehabilitation, the benefit is maximized. Your body isn't just a collection of joints or organs. It's a network of interacting systems, each influencing the other. Understanding how motion, vision, and rhythm integrate helps explain why some interventions reliably improve independence, while others have less impact. You step off the curb, the pavement is uneven, your knees shift, your hips flex, your eyes track a distant car. Every step relies on strength, balance, and coordination. Research shows that small changes accumulate over years. Hip osteoarthritis that limits walking can lead to progressive muscle atrophy and reduced mobility. Studies from the Journal of Bone and Joint Surgery indicate that older adults with untreated advanced hip degeneration are more likely to experience a decline in daily function over 5 years. Knee degeneration behaves similarly. Without adequate quadriceps strength, joint instability increases. NIH-funded research predicts that older adults who do not engage in structured strengthening programs have a higher probability of falls and loss of independence. Strengthening exercises reduce joint load and improve gait mechanics, lowering fall risk and supporting mobility. Vision loss due to cataracts can silently affect long-term health. Cohort studies from the American Academy of Ophthalmology show that delayed cataract surgery correlates with a measurable increase in fall risk, driving limitations and slower recovery from injuries. Restoring lens clarity improves visual input, which is critical for balance and spatial awareness. Cardiac rhythm disorders, when untreated, affect cerebral perfusion and energy availability. Evidence from Heart Rhythm Society registries shows that pacemaker implantation for bradycardia reduces syncope episodes and supports functional independence. Patients with properly paced rhythms maintain higher levels of daily activity and cognitive performance than those without intervention. Across systems, the trend is clear. Interventions that restore or support core function, mobility, vision, heart rhythm, correlate with better long-term independence. Meanwhile, procedures addressing pain or aesthetic concerns without addressing underlying function show less predictable impact on life quality. Over time, these factors interact. Reduced mobility leads to weaker muscles. Weaker muscles increase fall risk. Vision or balance deficits exacerbate this cycle. Evidence-based interventions interrupt it. Timing, rehabilitation, and adherence to structured therapy all influence the probabilistic outcome. The lesson is practical. Choices made now about movement, vision, and heart support shape the trajectory of independence over the coming decade. Small, informed decisions compound. You sit in a clinic exam room. The doctor reviews a chart. Fingers trace lines across the page. Recommendations appear precise, yet behind them, decades of research shape every suggestion. Hip replacement surgery is strongly supported by orthopedic consensus. The American Academy of Orthopedic Surgeons, AAOS guidelines, recommend total hip arthroplasty for older adults with advanced osteoarthritis when conservative therapy fails. Evidence shows improved mobility, reduced pain, and sustained functional independence. Timing matters. Earlier intervention when mobility declines begins can enhance recovery and long-term outcomes. Cataract surgery also has widespread consensus. The American Academy of Ophthalmology and multiple large cohort studies agree that removing significant lens opacities improves visual function, reduces fall risk, and enhances quality of life. Surgery is generally low risk and outpatient. Pacemaker implantation for symptomatic bradycardia or certain conduction disorders is supported by cardiology consensus. The Heart Rhythm Society and clinical trials confirm that pacing reduces syncope, maintains cardiac output, and improves functional capacity in older adults. By contrast, spinal fusion for age-related back pain without nerve compression remains debated. Some guidelines, including AAOS, recommend exhausting non-surgical interventions first. Evidence indicates similar long-term outcomes between conservative therapy and surgery in selected patients. Knee arthroscopy for degenerative arthritis is another area of cautious guidance. NIH-supported randomized trials suggest limited benefit for age-related cartilage wear. Experts generally recommend structured physical therapy and exercise before considering surgery. Even elective cosmetic procedures carry age-related risk considerations. The American Society of Plastic Surgeons emphasizes thorough preoperative assessment for older adults, recognizing slower healing, anesthesia sensitivity, and recovery demands. Overall, consensus emphasizes interventions that restore function and independence have strong support. Procedures for pain or appearance alone require careful consideration. Timing, rehabilitation, and individual health status influence outcomes. This guidance reflects decades of data, expert evaluation, and peer-reviewed evidence, providing a roadmap for older adults and caregivers to make informed decisions aligned with long-term independence. You walk down a hallway, each step deliberate. Your eyes track the floor, your muscles tense. These small movements reveal the habits that shape long-term independence. Evidence shows that simple, consistent actions can support mobility, vision, and heart function, even without immediate surgical intervention. Structured physical activity, including low-impact strength and balance exercises, maintains muscle mass and joint stability. NIH studies suggest that older adults adhering to regular programs have a lower probability of falls and maintain higher functional independence. Routine vision checkups allow timely detection of cataracts and other ocular changes. Cohort studies indicate that earlier intervention correlates with better visual function and safer navigation of daily environments. Periodic cardiovascular monitoring can identify rhythm changes like bradycardia before symptoms worsen. Registries from the Heart Rhythm Society show that patients monitored appropriately are more likely to receive interventions that maintain function and prevent complications. Other practical considerations include optimizing lighting in living spaces, using supportive footwear, and ensuring home environments reduce fall hazards. These measures complement medical interventions. The key principle: think function first. Focus on supporting muscles, joints, vision, and cardiac rhythm with evidence-based strategies. Decisions about surgery or procedures should be made in consultation with a healthcare professional who can interpret your health status and goals. Small, consistent actions, exercise, monitoring, environment optimization, compound over time. They shape the trajectory of independence and reduce reliance on urgent interventions later. You sit back in your chair. The sunlight shifts across the room. You stretch your arms, testing the joints. Small movements, deliberate. You notice what works and what doesn't. The choices you make today don't just relieve pain or address a single symptom. They shape your independence over months and years. Evidence shows that supporting mobility, vision, and heart function has measurable benefits for long-term function. It doesn't require dramatic action. Regular activity, timely checkups, and thoughtful discussion with your healthcare provider matter more than rushing into procedures. The interventions that restore core function, hip replacement, cataract surgery, pacemakers, can meaningfully improve daily life when timed appropriately. Others may offer limited benefit, especially if the goal is symptom relief alone. Look at your daily routines. What small step could support your strength, your balance, your vision, or your heart rhythm? What conversation could you have with a professional that would clarify your options? The path ahead isn't perfectly predictable. There are choices to make. But understanding the evidence, watching your body closely, and acting with purpose gives you control over the years ahead. Independence isn't guaranteed, but it can be actively supported. This content is intended for educational purposes only and does not constitute medical advice. It is not a substitute for consultation with a licensed healthcare professional. Individual health circumstances vary, and decisions regarding diagnosis, treatment, or surgery should be made with a qualified medical provider who can assess your specific situation. The examples, research findings, and recommendations presented are based on publicly available studies, consensus guidelines, and reputable health organizations, but they may not apply to every individual. Always discuss any medical questions, concerns, or planned procedures with your doctor or other qualified healthcare professional before taking action.